Nitesh, can we go ahead with the
Yes,
second session of case studies, please?
absolutely, absolutely. So I will then share my screen.
Yeah. The first
So
case
let
is
me,
dapagliflozin raising magnesium by 50 to 70% in patient with severe hypomagnesemia.
yes.
Yes, sir.
So let me just, I don't see the share option right now. So let me find it. Not sure why.
Just a second, sir.
Oh, there
Just a
you go.
second.
There you go. There you go. Okay. So I'm ready here. Okay. Are you able to see my slides?
Yes, sir.
Okay. All right. Very good. So let's then talk about this particular case, as Dr. Upain mentioned. But before we dive into the depths, the question that we want to ask is, can dapagliflozin raise serum magnesium levels by 40 to 60% in patients with hypomagnesemia? Yes or no? And to find out, let's dive a little bit more into the depths of this scenario. Now, as you know, that hypomagnesemia typically is seen in hospitalized patients, and um, it's not very common in ambulatory patients. And we also know that hypomagnesemia can contribute to hypertension, can contribute to ventricular arrhythmias, which is the most common cause of sudden cardiac death. And hypomagnesemia can also create insulin resistance and can affect insulin secretion. Now, here I have this patient who is 45 years old, Caucasian female, and comes to me with a long-standing history of type 1 diabetes. Patient also happens to be obese, and she's diagnosed with severe chronic hypomagnesemia for about 3 years. It's believed to be from renal wasting. She's leaking magnesium through the kidneys, and the reason for a kidney leakage of magnesium is not very clear. But she does not have a history of chronic diarrhea. She does not have a history of alcohol abuse, diuretic use, or proton pump inhibitors, which can create or contribute to hypomagnesemia. Now, this particular patient, I was surprised when I saw this. And the patient says, Doc, treatment wise, I have to get infusion of magnesium sulfate. They give me 4 grams intravenous every 3 weeks. And I'm also taking a magnesium oxide in the oral format. I'm not able to tolerate higher than 500 milligrams per day dosage, because if I try higher, I get very bad diarrhea. And so when I looked at her data, and I'm sharing this with everybody here, and so, despite being on IV magnesium and oral magnesium, her serum magnesium levels are still hovering around 1.1, 1.2 milligrams per deciliter, and the normal reference range here in the lab is 1.8 to 2.4. So again, on the lower side, and these are her rest of her labs, really unremarkable: normal calcium, phosphorus, vitamin D levels, normal parathyroid function. And what you can see here is, the urinary magnesium is 77. So this is again 24-hour urine magnesium, and ideally it should be less than 41. So clearly this patient is leaking magnesium in the urine through her kidneys, but we really don't know the etiology. Now, be that as it may, I'm really very concerned about this case. When I see her for the first time, she continues to have generalized fatigue and weakness. So I said, what do I do for this patient? And in my background and in my mind, I had some following information about magnesium and SGLT2 inhibitors. And when you look at this particular data that I'm showing you here, This is a beautiful paper by Christian Mendy's group in UC San Diego. And what they're showing is that if your serum magnesium levels, are less than 0.74 millimoles per liter, and you add Invokana, which is canagliflozin, and 100 milligrams is shown in this particular color code, and 300 milligrams is shown in dark blue color code compared to the placebo, which is shown in green. What do we see? What do we see here? So in this particular group, we see approximately 15 to 18% increase in serum magnesium. Now, when you look at the data on the right-hand side, if your serum magnesium levels are 0.74 millimoles per liter and higher, we see about 5% increase in serum magnesium. And so I was aware of this particular data. Now, when you look at the proportion of patients in the very same study, it turns out that 75 to 80% of patients in the trial had those type of serum magnesium increases that I just shared with you. And then came another paper from Chinese group, which is a meta-analysis, wherein they combined all the SGLT2 inhibitor trials that evaluated the impact on serum magnesium. And here with the canagliflozin, again, we see with all these studies included in this meta-analysis, we see a favorable trend towards increased serum magnesium. And then we saw the same with dapagliflozin, empagliflozin, and also epagliflozin, wherein we see a favorable trend overall, collectively, and also individual studies that were a part of this trial showing an increase in serum magnesium. And so I realized that, hey, this could be a class effect of SGLT2 inhibitor. And so I said, can my patient that I just described benefit from adding SGLT2 inhibitor? So with this thought in mind, I added 10 milligrams of dapagliflozin, which was covered by her insurance. And then I also thought that this would also benefit her diabetes, although it's type 1, but she's obese type 1s. And I've been a part of many studies wherein we have shown that SGLT2 inhibitor is also beneficial in the setting of type 1 diabetes. We again continued the IV magnesium infusion every 3 weeks that she was on, and we also continued her oral magnesium supplementation. What did we see when we added dapagliflozin? So here on this graph, I'm showing you that prior to the addition of dapagliflozin, our magnesium levels are low, around 1.1, 1.2. As soon as you add 10 milligrams of dapagliflozin, I was very, very impressed with this peak rise all the way up to 2.6. Fortunately, it was not sustained at this level, but still, when you look at the overall net effect, the magnesium levels are still higher when you continue the dapagliflozin compared to prior to the addition of dapagliflozin. And now her serum magnesium levels are maintained around 1.6, 1.5 range, very close to normal, not quite normal because the normal range is 1.8 to 2.4, but here we still get it pretty close to a 1.6 milligrams per deciliter. And here again is the trend overall of magnesium while on dapagliflozin. Look at her urine magnesium. Now it's less than 41. So previously she was leaking about 77 milligrams per day. With addition of dapagliflozin, that leakage has really stopped, and patient feels remarkably better. Her fatigue and weakness has gone better, and not to forget, our A1C control is also much better than before. We overall see about 0.5 to 0.8% reduction in A1C overall with dapagliflozin. So what are the possible mechanisms? Again, we don't know for sure, but we believe that SGLT2 inhibitors, and in this particular case, dapagliflozin, could affect TRPM6 and TRPM7, which are your channels in the kidney that modulate your magnesium levels. So that could play a factor. We also know that with SGLT2 inhibitor class, we see about 25 to 30% increase in the glucagon levels, and a rise in glucagon has shown to promote an increase in magnesium reabsorption. Be that as it may, this benefit seems to be independent of glycemic control. And so as an investigator, I feel that somebody needs to establish a direct link between SGLT2 and TRPM6 to really prove and support our discussion. And so I would like to conclude case one by saying that a treatment with dapagliflozin in this patient with chronic hypomagnesemia, despite being on IV and oral magnesium, led to about 40 to 60% increase in serum magnesium. And this has been unheard of so far, because as I showed you, the prior data, we have typically seen about 15 to 20% increase, versus here we see 40 to 60% increase. One of the reasons could be that in this particular case, the serum magnesium levels are kind of very low, and that's why the percentage increase is much higher compared to a 15 to 20% rise, wherein we see the baseline A1Cs when you translate baseline sort of serum magnesium, when we translate to milligrams per deciliter, is probably somewhere between 1.2 to 1.6 milligrams per deciliter. And this could have severe implications for patients with severe hypomagnesemia, as we just saw, because it can improve the symptoms and the quality of life of the patient. So again, this case has been submitted for publication. It's under review, but I would like to take questions related to the first case, and then we can move on to case two. And so the answer to the initial question is yes, it can. Dapagliflozin and possibly other SGLT2 inhibitors can raise your serum magnesium by 40 to 60% if your baseline levels are very, very low. So thank you again. Please ask me questions about case one, and then we'll talk about case two.
Okay, we'll take the questions together. We can directly move on to the second case, that is pembrolizumab induced hypoparathyroidism and hypocalcemia.
Yes, let's do that. Let's do that. So again, the second case, again, very fascinating case. And the question here, before I discuss the case in detail, we want to ask is hypoparathyroidism a known side effect of checkpoint inhibitors? And this family of checkpoint inhibitors is now very commonly used in patients with different types of cancers. And actually the two physicians or scientists who kind of helped discover this class of drugs were recently awarded the Nobel Prize in medicine because it's really been game-changing for the survival of patients with different types of advanced cancer. Now, when you look at the most common cause of hypoparathyroidism, as my esteemed colleagues on this call know, it's either autoimmune or post-operative or post-surgical. And in adults, the post-surgical is the most common cause, but drug-induced hypoparathyroidism continues to be very rare. And so here I have a 71-year-old Caucasian male, has a history of malignant neoplasm of the right bronchus. And so the classification for the cancer is stage 3B. And then the upper lobe of left lung and the bronchus is also involved. And so this patient receives radiation therapy, 2 courses of radiation therapy as per the standard of care guidelines. And then fortunately, he becomes eligible for Pembrolizumab, which is a checkpoint inhibitor commonly used in advanced lung cancer. And this patient then gets given 200 milligrams of intravenous Pembrolizumab every 3 weeks. And remember that the patient gets this therapy approximately 5 years after the initial diagnosis of cancer. And when you look at the baseline calcium for this particular patient is about 9.2 milligrams per deciliter, range is 8.5 to 10.2. So we have documentation of normal calcium levels prior to the start of pembrolizumab. There's no history of autoimmune disease, neck injuries, or exposure to a neck radiation that could subject the patient to hypoparathyroidism. And I apologize for the typo here. The spelling of radiation is incorrect. So I apologize for that. But patient does not have any risk factors for no other risk factors for hypocalcemia. So let's focus on this particular graph, and let me just orient you to this graph. On the x-axis, we are showing the duration of therapy in months, and on the y-axis, we are showing the corrected serum calcium levels. And here, prior to the start of pembrolizumab, as we discussed, the corrected calcium levels are normal, but after the 13th dose, the calcium levels begin to decline. And as you can see, the overall trend continues to show that the corrected calcium level starts to decline more and more. And the lowest point that we see is close to about 6.4 milligrams per deciliter. And despite such low calcium levels, fortunately, patient didn't have any signs of tetany, did complain of fatigue and weakness. And when the fatigue and weakness was profound, this metabolic panel was done, and the corrected calcium was shown to be very, very low. And so at this point, he gets 1 gram of calcium chloride, and he gets 3 such doses. He gets 1 dose of calcium gluconate, 2 grams. He receives a dose of 0.25 micrograms of calcitriol. And then, as you can see with this therapy, his calcium levels, they start to go up back into the normal range. And then as maintenance, he requires 0.5 micrograms of calcitriol, which is the active form of vitamin D. And I still continued the D2 form of vitamin D, 50,000 units once or twice a week, depending upon the situation. And I'll tell you in a minute why I did that. Now, when you look at his parathyroid hormone levels, again, we don't have a baseline prior to starting pembrolizumab, because we didn't expect that he's going to have some sort of parathyroid issue. But when you look at his trend of parathyroid hormone levels, as you can see, over the course of pembrolizumab therapy, it continues to decline, and turns out to be as low as maybe 3 or 4, 28 to 30 months into the pembrolizumab therapy. Now, the reason why I still continued 50,000 units of vitamin D2 was with the hope and expectation that although his PTH levels are low, but might still help with the conversion of the inactive form of vitamin D into the active form, and further facilitate the rise in the calcium. Now, we tested for calcium sensing receptor gene mutation, and it was a negative. So what could be the possible mechanisms, that pembrolizumab can contribute to hypoparathyroidism? So could it be autoimmune, and when we say autoimmune, what can contribute to the autoimmune component? And so the increased T cell activity, which happens with checkpoint inhibitors like pembrolizumab, can then affect your parathyroid tissue and can destroy the parathyroid tissue. You could also have development of calcium sensing receptor autoantibodies that can further lower your PTH levels. And it's not clear whether this phenomenon is permanent, or if we stop the pembrolizumab, can we expect to see the resolution of the calcium levels? So these are all these are all questions that remain unanswered at this point. But how rare is this situation? And so only 3 cases have been reported globally. The case that I just presented is the 3rd case known globally. In our case, the fall in PTH and calcium started after the 13th dose. When you look at the 2 prior cases of pembrolizumab, the fall in calcium levels happened after the 15th dose and the second dose respectively. So again, when this will happen, nobody knows. And so the message for us as clinicians is, if you have somebody on pembrolizumab or other checkpoint inhibitor, we want to periodically monitor their PTH and calcium levels, not knowing when this phenomenon will evolve. It can happen as early as second dose and as late as a 15th dose and later. So again, very important. And does this happen with other checkpoint inhibitors? And so recently, the 2 checkpoint inhibitors called ipilimumab and nivolumab, which are concurrently used in patients with advanced melanoma, we saw that there was a fall in calcium after 1.5 months of therapy. So again, just I want to bring out an important message for clinicians that um, uh, hypoparathyroidism can happen with checkpoint inhibitors in addition to other commonly seen endocrine disturbances with this family, like adrenal insufficiency, thyroid dysfunction, and pituitary dysfunction. So we want to carefully monitor their endocrine function so that if something were to happen, we can catch things very early on. Again, I'm very happy to share that this case is going to be published in the upcoming issue of ACE, a clinical case reports journal, and you guys will be able to see this in print. So again, the answer to the question that we earlier asked is yes, and so we should be very vigilant in this group of patients. So thank you again, SwasthyaCON 2021 and the organizing team for your efforts and for inviting me to present. It's been a great joy and pleasure, and I'm sure everybody learned a lot. Any questions regarding these 2 cases?
Yeah, thanks a lot, Dr. Nitesh. Dr. Vishwa here.
Yes.
Yeah. Oh, that was very wonderful. 2 of the cases, very new, very unique. And I'm very happy to see the way you managed it and the outcome of the cases. For first case, I'd like to ask you that DAPA or SGLT2 that you have used for hypomagnesemia in that patient. The question here I have is whether the baseline kidney function in patient with hypomagnesemia would affect your selection of SGLT2 inhibitor, or whether you will refrain if the patient is having advanced CKD or stage 3, stage 4 CKD, still you would be opting for SGLT2 inhibitor in this patient, or baseline kidney function is normal, then only you will give. That is my question for case 1.
Yes, a very good question, Vishwa. It's a fantastic question. So again, as we saw in this particular case, her renal function was fine, her BUN creatinine was very good, her GFR was very good, and we still saw a benefit. We also have similar data in terms of magnesium normalization, not to the extent that I showed you, because again, 40 to 60% is really not seen that commonly. But when we have looked at patients, have received a kidney transplant, and those patients, even if the GFR was, as low as 20 or 25 or as low as 30, again, these patients have benefited from the ability of the SGLT2 inhibitor class to normalize the serum magnesium. And incidentally, patients, with a stage 3 CKD or higher with kidney transplant are actually more prone to have a hypomagnesemia. And so I was very excited to see that particular paper, which is from one of the kidney transplant groups from University of Virginia, wherein they're showing that even if the GFR is lower, these patients with kidney transplant with hypomagnesemia, they show a remarkable improvement in their magnesium levels. And now when you look at the label, right now we say, hey, it should be used only if the GFR is higher than 45. And this is, again, what the indication is for this a group of medications, at least in the United States, and I'm sure that the label indication is very similar in India and Europe. And as I was earlier mentioning, that the reason for that cutoff is because these drugs were initially licensed for diabetes control. And since we didn't see a benefit, as much benefit with diabetes control with a GFR below 45, we came up with that cutoff that we should use it only if the GFR is above 45. But since that time frame, or since the launch of SGLT2 inhibition, we have seen some amazing cardiorenal, cardiometabolic, including its ability to normalize serum magnesium, even in patients with a lower GFR, with a very robust safety and efficacy. And I'm sure that this GFR cutoff, in the future is going to change as we talk more and more about this data, and more of this comes more mainstream and more in the public domain.
Okay, thank you. Second question related to same case. As we all know that magnesium level, hypomagnesemia is generally either GI loss or inability to rather absorb, or it may be at the kidney loss, right? So is there any data or theory or suggestion that even SGLT1 inhibition anywhere, probably in GI or somewhere other places, is helping us to get the magnesium level normalized?
Yes, again, a fantastic question. And so it is quite possible, because if there is a GI loss responsible for hypomagnesemia, then using this combined SGLT2 and 2 inhibitor, wherein you have predominant SGLT1 population in the gut, by using SGLT2 inhibition, you can enhance the absorption of magnesium at the level of gut, and we might be able to see a benefit in this patient. And so in my clinic, if I see a patient with hypomagnesemia with GI loss, I would certainly try this and see how things go.
Good. One last question for case number 2. See the epidemiology of cancer all over the world, the numbers are increasing, and these checkpoint inhibitors have now started being used fairly commonly, right? So suppose at baseline, many of these patients may have hypocalcemia or parathyroid related antibodies, or frank hypoparathyroidism itself. So would you refrain this particular patient from giving checkpoint inhibitors, or is there any other guideline recommendation, those who are already having hypoparathyroidism or hypocalcemia at baseline, at diagnosis of cancer, and those who are the ideal candidate for checkpoint inhibitors?
Yes, another great question. And so when we sort of encounter this type of scenario, and when we are making a decision, obviously we want to think of improving the patient's survival first. And what ideally I would do in this situation is, put them on calcium supplementation proactively. If they already have an existing problem, and knowing that with the checkpoint inhibitor is likely to worsen over time, I would proactively put them on calcium supplementation and monitor their PTH and calcium levels very closely, and adjust their therapy based on how they respond. And as you know, calcium management, if we know what we are dealing with, then calcium management is relatively easy if the checkpoint inhibitor is going to enhance the survival of the patient. But in my clinical practice, what I've been doing is, since I've become more aware of this, I have a very established referral system with one of the largest cancer groups in town. And I have had a discussion with them, said that any patient that put them on checkpoint inhibitor, I've given them a guidance that please check this endocrine functions, as baseline. So we know over time what is happening. So I tell them to check the pituitary gonadal axis. So I tell them to check LH, FSH, total testosterone, SHBG. So we know what is going to be the impact on that. I have them check ACTH and cortisol levels, so we can test out the pituitary adrenal axis. I also check the baseline prolactin, because there have been reports wherein checkpoint inhibitors can also raise your prolactin levels, and then a total thyroid panel in the beginning as a baseline, TSH, free T4, free T3, and TPO antibodies and TSI if possible, because again, checkpoint inhibitor can cause hypothyroidism, can also cause hyperthyroidism. And so it's important to have those baseline antibodies. So I've given them this list, and I do the same in my practice. So I establish a very good baseline endocrine function testing prior to the start of pembrolizumab and co-manage with the cancer groups.
Thank you, Nitesh sir, and thank you chairpersons for this wonderful discussion.